The Healthcare Labyrinth Podcast is back for another episode. Join Marc S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this edition of the Healthcare Labyrinth Podcast. My name's Marc Ryan, and it's a pleasure to be hosting the podcast. And thanks to everyone for listening in. Today, we're going to stick to our Medicare Advantage topics here and really discuss a very, very interesting new phenomenon that is out there. And it really all began with Humana CEO Jim Rechtin, who is brand new, Bruce Broussard, who is sort of a legendary leader at Humana, who really built the company up over about a decade or more, retired as of the end of June. And Jim came in as the new CEO. Jim has a very strong background in healthcare. He was recruited to become the successor to Bruce, and he's sort of hit the ground running at Humana. Now, I have great admiration for Humana as a corporation. I really do believe that Bruce Broussard was a visionary, and he really built a very incredible company. It's very much centered on Medicare Advantage. He's sort of pulled out of the commercial line and has a small growing Medicaid line, but very much based on Medicare Advantage, which some people take issue with. Some people believe that you should have a more diversified insurer across all lines of business, but Bruce did decide to focus on what was and what I think will always will be a very strong part of an insurance business, having the greatest premium and having the greatest potential to succeed. I will admit that right now Medicare Advantage is struggling, and so is Humana. But I still think that his legacy and his growth of the business over time has to be admired. Now, Jim did come in, was under Bruce for about a year, but Jim is trying to define himself as his own CEO too. And recently he made a little bit of a wave at his Q2 2024 investor call. Now, he sort of did it in two ways. Number one, he basically sent out all his financial detail and again, in great detail to investors and said, here it is. I'm not really going to talk about it. I'm going to take questions about it at the Q2 2024 investor conference, but I want you guys to digest it. I'm not going to go through my normal dog and pony show that we do. The numbers are the numbers, and we're going to join basically with just a short overview and have you ask questions. And we're going to have a very good discussion about where the company is today and where it's going in the future. So that was a novel, right? Because many executives would rather talk about the financials and put the best spins on them as opposed to just putting them out there and letting questions fly. But more importantly, during that discussion with investors, Jim made on that investor call a very important signal that he believes Medicare Advantage has to transform and be more accountable to the government and the Americans it serves. And that is, again, not something you normally see. I think Medicare Advantage executives are always looking to create a good value proposition in the marketplace and attract members. And I think most of them do it honestly and ethically, and they're strong business people. But in this case, Jim layered in another nuance. He basically said that in addition to just creating value and growing, we need to show the government and the Americans we serve how valuable our product really is. And we also need to reach out to these constituencies, Americans, as well as the government, and give them pieces of our value back. We can make it, he basically said, and do well by giving back more to the Americans and especially more to the government. And this comes at a very, very interesting time, given Medicare solvency is on the brink of going under here. The Part A trust fund, although it has been extended a bit, it's only about a decade before we have true solvency issues. And while that might get pushed out every so often, just because of economic trends and things like that. We know that Medicare is on the brink of insolvency, and we need to do something phenomenal in this area. And a bit of what Jim was responding to were charges out there from Capitol Hill, from advocates, as well as from others, even within CMS, that basically said maybe Medicare Advantage has it too good. There is a great deal of talk of major overpayments, and it's time for us as a regulator in terms of CMS, Capitol Hill, to rein in what's going on in Medicare Advantage. So in some ways, Jim was basically sending that signal that he is ready to lead an effort, at least at Humana and perhaps throughout Medicare Advantage, to transform, be more accountable to the government and the Americans it serves, and allow those folks to recoup, especially the government, some of that value that Medicare Advantage plans provide. Now, I will note that several other prominent MA executives have talked about a similar thing. Andrew Toy of Clover Health has been very outspoken on the fact that rates are what they are and we can deal with them, and that we have a duty to provide value. John Cow of Alignment Healthcare has talked very much in the same way, and so is Sachin John of Scan Health Group. But these folks, Jim Rechtin from Humana, Andrew Toy of Clover Health, John Cow of Alignment Healthcare, and Sachin John of Scan, have all really begun to set in motion the idea that things have to change at Medicare Advantage plans. They have to be more open and transparent, and they have to give some back, and perhaps stop some of that jockeying against Capitol Hill, against CMS, and be honest and transparent and enter into a collaborative relationship with CMS and Capitol Hill to get this fundamental transformation of MA done. So with that introduction, we're going to take a quick break. We'll take several breaks here, and we'll come back to break down a little bit of the landscape that is causing Jim Rechtin of Humana and others to say we need to start to do something differently. Be right back.
Health plans and insurance are confusing. Our healthcare system is in dire need of reform. Health policy expert Marc Ryan tackles both issues in his book, The Healthcare Labyrinth. It is both a guide to navigating health plans and fixing American health insurance. Marc dives deep into how health plans and the American health insurance system operate. He then outlines a comprehensive reform agenda for the system as a whole, including pricing, emphasizing health and care management, and ensuring affordable access to health coverage in a private delivery model. Marc is a bit of an unconventional Republican in that he believes affordable access is the morally right thing to do, and that it is also fiscally prudent for our nation. Learn more about Marc's book, The Healthcare Labyrinth, at healthcarelabyrinth.com or search at leading bookseller websites. Available in print, ebook, and audiobook forms.
Welcome back, and we hope you're enjoying this episode of the Healthcare Labyrinth Podcast. We're talking about MA being more accountable, and Jim Rechtin of Humana, as well as several other MA executives, saying that it's time for some change. And so let's break the issue down a little bit. I mentioned the fact that MA plans are sort of playing a bit of a cat and mouse game with CMS, and a couple of different things that Jim has sort of called out here. Number one, today, in many ways, Medicare Advantage plans are not showing the clear value over the traditional Medicare fee-for-service program, and they may need to do a little more of that. A lot goes into this, but it has a well-documented record of savings, better quality, and satisfaction among enrollees. MA serves a disproportionate number of people of color and those who are of lower income. And as I often say, MA has become the greatest social safety net program in America. It literally saves seniors and those with disabilities thousands a year in out-of-pocket costs and coverage for other things that are not traditionally covered in Medicare. And sometimes that savings can even be tens of thousands of dollars a year. especially if someone has a catastrophic event. See, Medicare Advantage plans tend to fill in the voids in the traditional Medicare system. In addition, a lot of studies show that quality is much greater. There's better preventative treatments. There's better chronic disease management. There's better navigation of the system by MA enrollees compared to the traditional fee-for-service program. So Jim, on that investor call, said, first and foremost, we have to tell a better story about the value we truly bring and bring a human element. Talk about it through the eyes of an enrollee when we do that. So that I thought was a great point. Number two, at the same time, I think Jim and some of these other executives at Alignment, at SCAN, and at Clover Health are sort of intimating that Medicare Advantage may have too much of an advantage, so to speak, against the traditional program. Now, I am the last guy to argue that a lot of what is said out there by opponents is accurate. It clearly is not. And that's a big problem. But what I think Jim and others are saying is that we have to begin to recognize some of the over-reimbursement and some of the advantage that might just be too much against the Medicare fee-for-service program and be willing to be more accountable, reform a bit, and perhaps give some of that back. And so let's talk a little bit about the pros and cons of that here. Well, number one, broadly speaking, the opponents out there are arguing somehow that Medicare Advantage is over-reimbursed up to $80 billion annually. It's funny, but I just saw a number well over $100 billion. And really what these opponents are doing are throwing in everything in the kitchen sink to come up with these numbers. They talk about the fact that in some respect, rates in some areas of the country are over 100% of fee-for-service. I often push back on that because that was a deliberate move by Congress to try to get rural and more suburban areas better penetration of MA. So that was a discrete policy choice at the time when it was done. They also criticized the fact that the STAR quality rating program has additive dollars in the MA program and not budget neutral, like is the case in almost every other STAR program in the fee-for-service world. They are also throwing around, and again, I would say on that one, Congress made a deliberate decision to do that because so many people were being served and they wanted to send a message to incent quality. So it's hard to agree with opponents' criticisms of the additive dollars in STAR. On the next issue on beneficial selection, many advocates, I think very unfairly, and researchers are basically arguing that there's huge beneficial selection within the program. I'll get to risk adjustment in a second, but that beneficial selection alone, they say, means huge overpayments to the tune of tens of billions of dollars a year. I don't buy it. There's as much research on the other side that talks about low-income individuals and those with social determinants of health that are enrolling in the MA program at greater rates than in the traditional fee-for-service program. So I sort of throw that one out. Perhaps the best one that I would say opponents come up with is the fact that there is a risk adjustment system and it tends to over-reimburse Medicare Advantage compared to what the risk adjustment scores are in the fee-for-service program. But again, here, I think there are truths and falsehoods. Let's talk about the falsehoods first. I think every time a Medicare Advantage plan scores an individual greater than the fee-for-service program, that is not fraud. That is not an overpayment. That is not some skullduggery that a MA plan is engaging in. I think it is very true that in the fee-for-service world, there is no incentive to capture all of the diagnoses that a person has, and that MA is doing a better job of capturing diagnoses compared to providers reporting into fiscal intermediaries in the fee-for-service program. And so that I don't think is a valid criticism. I think it's a falsehood. But I do tend to begin to agree with some of the advocates and opponents of MA when they talk about the fact that in some cases, the risk adjustment system is being abused by MA plans and plans are getting overpaid. And I would argue that there's a couple of things here. Number one, I do believe the studies do show that there are a small number of plans that are outliers in terms of how they perform in risk adjustment. They are tremendously over-reimbursed, and they account for a great deal of the over-reimbursement. So a small group of bad actors may be giving the entire MA program a bad name. And I would also go to two other points that I think probably are ripe for reform. They are in these areas. Manual chart review submissions to boost risk adjustment scores. I do not believe that should be allowed to continue. A plan, if somebody has, one of their enrollees has a disease state, it should be reported on an encounter from a provider. And we probably should do away with manual chart reviews. They could be used to help ensure correct encounters are being submitted, but they probably shouldn't be additive, especially because in many cases, those chart reviews are the first time that you ever see a given disease state for an individual. They are not coming on encounter submissions from providers. I would also call out health risk assessments. And plans are hiring firms to go in and have clinicians evaluate disease states and conditions of individuals, and they are then submitting those manually as well. And my view of this is that, again, in many cases, these health risk assessments have disease states on them for enrollees that are never reported later by a practitioner on an encounter. And that probably needs to change. So in general, let's sum this part of it up to say that, again, MA may have a little more of an advantage than they deserve. And I think that's what Jim Rechtin from Humana is saying. Some of the reimbursement is good policy, like additive star dollars, or paying certain counties over 100% fee for service. But some of them, perhaps some risk adjustment practices need to be reformed and reined in because there may be some overpayment out there. Next, let's talk a little bit to put all this in context about some of the reaction of CMS recently. And this is another reason why Humana's CEO is saying we might want to do something on our own about this, because CMS is beginning to react to these charges of overpayment and the negativity on Capitol Hill and beginning to make changes. And these changes may or may not be best for the program. So in this case, let's talk about a few of those obstacles that CMS has put in front of MA plans recently. Well, we just talked about risk adjustment, and in reaction to so-called overpayments, recently CMS laid out a new risk adjustment model that from 24 through 26 will take about 7% out of the rate setting system. It came at a very, very bad time for MA, because they were starting to see utilization increase in 24 and 25 going into 25. And this came at a very bad time. It really has meant negative rate increases in 24 and 25 and potentially another one in 26. And that creates problems. Now, fundamentally, I do not disagree with CMS putting refined models in there that make sure that plans are not over-reimbursed. And so that's fine. I think risk adjustment models need to be refined. It just happened at a wrong time. And it was really in response to the mammoth overpayment articles out there from opponents that said this thing has to be reined in. Number two, CMS unfairly attempted in 24 to implement a major star change without being honest and upfront with plans. They sought to put this Tukey outlier that theoretically promotes better outcomes because it removes outlier performance from the calculations, but they did not implement it right, and they did not implement it with the correct guardrails, and therefore they sought to take more money than they were allowed to under the regulation out of that STAR reimbursement system. But again, one of the reasons that CMS did that was because there is criticism of overpayments. And so they wanted to save dollars there, and they attempted to do that. Two judges overruled that, and they had to go back to the status quo there and implement the guardrails correctly, even though the outlier formula was allowed to be put in. So it will take a number of years for CMS to recoup the savings from the outlier change as opposed to getting it all in 1 year. They also unveiled, CMS, a new risk adjustment rule, which had a number of unfair provisions in them. Again, this was because of the overpayment issue, but CMS sort of went well beyond, I think, their regulatory authority, sought to implement the rule retroactively for prior years. They are not doing what's known as a fee-for-service adjuster in the rule that I think is unfair. And I do think there's other problems with it, including going well beyond the Administrative Procedures Act allowances. So this is in court. It will likely be thrown back to CMS to reform it because at least pieces of it will be determined to be extra legal or extra regulatory. But again, a reaction to the overpayment issues out there. And lastly, in this category, I would say that CMS just implemented new prior authorization restrictions. The provider lobby, the hospitals, and the AMA went after this on Capitol Hill as well as to CMS. They argued that MA plans were being a bad actor on PAs as well as claims denials. And CMS came out with very restrictive prior auth rules, which essentially requires these managed care plans, MA plans, to follow the fee-for-service guidelines. I think it's atrocious. They've taken the managed care out of managed care. But again, a reaction to criticism of providers, a reaction to the overall issue of overpayments and things like that. And that's why CMS implemented the rule. So if you take all of these obstacles that CMS have put in front of MA plans, again, in summary, it's all a reaction to these charges of overpayment and having too much of an advantage. And that's yet another reason that Jim Rechtin from Humana said that perhaps we need to go on the aggressive now and try and create our own outreach in collaboration with CMS to show our value, but give some of that value back to CMS and Medicare as well. With that, we'll take our second break and we'll be right back.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back, and we hope you're enjoying this edition of the Healthcare Labyrinth Podcast. We're talking about making Medicare Advantage more accountable and the new Humana CEO, Jim Rechtin's idea that MA plans have to reach out to and build a very better value proposition with some savings back to Medicare and CMS. So we've talked a little bit about how MA needs to show a clearer value over traditional fee-for-service, how they may have too much of an advantage out there, and some of the obstacles that CMS and others have placed in front of MA just due to all the noise about overpayments. But let's now turn a little bit to the bright light that is shining on MA due to some questionable practices. And I've talked about one of them already. We'll just quickly go over that again. But to me, the three areas that are really being focused on right now are one, risk adjustment practices. As I mentioned, I don't believe that the majority of the overpayment discussion out there is accurate. And I don't believe they're over-reimbursed by 80 to over $100 billion. It's just nonsensical. But as I noted earlier, there are areas where a small group of plans are taking advantage of the system and giving everybody a bad name. I believe those plans need to be aggressively audited for their unseemly activities that are driving risk scores too far up in a disproportionate way for those plans and accounting for a great deal of the overpayments. So I do believe a RADV rule where plans are aggressively risk adjusted is important to root out those bad actors. I don't believe the rule that's out there that was passed is fair, and I think it has to be revised, but a good RADV rule and even extrapolation penalties that are used reasonably is not a bad idea to really clean up practices for these small number of plans. Next, I also mentioned the idea that health risk assessments and manual chart reviews should not be used exclusively to increase scoring. I believe that anytime you have a health risk assessment, that there should be an encounter for that disease state attached to anything found in the health risk assessment. I also think manual chart reviews should go away. It should not be the only place that you see a new disease state or a change in a disease state. That should come on an encounter as well. So the aggressive risk adjustment practices of at least a subset of plans needs to be cleaned up because these are clearly questionable practices. Next, the other big area that CMS and even Capitol Hill are now looking at, and it has generated a lot of controversy with the opponents of MA as well, are supplemental benefits in MA. We know that when a plan bids, it tends to be able to furnish traditional Medicare benefits at a lower dollar cost than what the traditional fee-for-service program does. And a portion of the county benchmark rate and the bid for traditional Medicare services is given back to plans, and they can create supplemental benefits. Well, in those bids, plans basically say what the utilization and cost of supplemental benefits are going to be. But there is admittedly a good deal of evidence that utilization of these supplemental benefits is low, and perhaps deliberately by some plans. And so plans really need to drive use of these benefits so they are not accused of taking lucrative rebates in the rate system simply to enroll more people and not using them adequately on benefits. CMS has begun to reform this area. They are requiring mandatory outreach and education on supplemental benefits, a utilization on a member-by-member basis that will be sent out mid-year of each year, as well as mandatory submission of encounters on supplemental benefits. It will take a long time to get there, but I think it's in MA plans' best interest to make sure that they are following this rule, that they are getting their supplemental benefit encounter submissions in, and educating and driving utilization to make sure that they maintain credibility. There's also a great deal of anxiety among many groups, myself included, about the rotten broker agent system that has emerged in Medicare Advantage. So there are these very, very large third-party marketing organizations that have basically sprung up. They have entered into what I think are unseemly and nefarious deals with the very largest plans, where essentially various extraordinary payments are made beyond the general new enrollee and renewal compensation that a direct agent and broker gets, to essentially funnel even more cash to these marketing organizations from the big health plans for steering members into these big health plans. And I think that is a very wrong thing to do. I believe that the small independent agents and the small agents and brokers act with integrity, and they are signing people up in the best plan possible for their needs. And I think some of these deals between large plans and third-party marketing organizations that involve implicit steering are not a good thing for the system. And it's hurting consumers, and it's ultimately hurting the MA program. So I believe plans should clean up their act. They should go to a transparent way of showing benefits and working with brokers with integrity. Unfortunately, a new regulation that CMS did throw out there was thrown out by court. It was a very good way of refining and reforming the agent broker compensation. It would have ruled out these extraordinary steerage compensation between the big plans and the large third-party marketing organizations. But I believe Congress should come back with CMS, pass a law that clearly defines that this is what they want to do so a judge can't strike it down and reform this system. So that's just a really quick overview of the three major things that have a bright light shining on them: aggressive risk adjustment practices, questionable supplemental benefits records, and rotten broker agent submission. With that, we'll take our last break here, and we'll come back just to sort of sum up what CEO of Humana, Jim Rechtin, is saying about what the future of an accountable MA world might look like.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Marc Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Marc's insights. Twice a week, Marc publishes a blog to go deep into a current issue. And of course, Marc hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Marc's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back, and we hope you're enjoying this episode of the Healthcare Labyrinth Podcast. So I promised to go through a little bit about what should the future be for MA. So in Jim Rechtin's long view and my long view, I think, MA reform is needed, and plans enter into a compact with CMS to save the Medicare system dollars because it is struggling with insolvency and drive the best quality possible. It logically means reforms in how MA plans are paid, how the STAR program is set up, and how benefits are delivered. It means also far more transparency and accountability on the part of MA plans. It makes a great deal of sense when you compare it to the current construct. Plans are struggling today in large measure because MA policy has become politicized. CMS and Capitol Hill are reacting to external forces because of some of the bad habits of Medicare Advantage plans. Without MA plans offering comprehensive reform proposals and having a willingness to change how they do business, I think the industry will continue to be victim of unwise and overreaching changes, such as the risk adjustment data validation rule I referred to, other prior authorization changes, and sort of indiscriminate rate setting changes that will really hurt Medicare Advantage worse than they have it already. In the end, creative reforms would mean an MA 2.0, let's call it, thoroughly endorsed by CMS and lawmakers, with quality and cost savings as featured values of the program and members at the forefront. While MA will continue to grow because of the better economics for beneficiaries, I think an MA 2.0 would actually bring an acceleration of further growth, bringing value to beneficiaries, the Medicare program, and MA plans alike. CEO of Humana Rechtin calls it, quote, a long-term value proposition for taxpayers that creates real stability, end quote, for Medicare and Medicaid. He sort of brings in Medicaid into this value proposition as well. He noted further, quote, "We need a regulatory environment that allows that value to be fully realized and that requires constant collaboration and adjustment. We need to be a proactive partner with CMS in that process, and we need to do this to make sure that we've got a long-term stable Medicare and Medicaid program," end quote. As he notes further, quote, "How do we actually collaborate with CMS to make sure that the regulatory environment allows that value to accrue back, or some of that value to accrue back? None of that should be harmful to the MA sector," end quote. The alternative for me would be MA plans on the defensive as they are today and the continued cannibalization of funding and operational and clinical independence. Many in CMS and Capitol Hill would like to make MA more like fee-for-service. In fact, if you look at the prior authorization changes, I said they're taking managed care out of a managed care program. To me, that is the biggest threat to MA and the members it serves. That means MA-led reform is very, very important. Reforming, again, how they bring in money, how they bid, how they spend on benefits, how they're much more transparent and accountable to the system. All of these are investments ultimately that MA plans would have to make. But I believe if they make it, they will be in far better shape over the long term than what policy and Capitol Hill would likely do to them over the years otherwise. With that, we'll end this edition of the Healthcare Labyrinth Podcast, and we'll see you next time. Take care.
Thanks for joining Marc and the Healthcare Labyrinth Podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth Podcast.